Good afternoon. I am Kwangsun Park from Seoul, Korea. In this Shockwave session, I will not simply repeat that ESWT can reduce myofascial pain. My goal is more practical, to change where we look and where we apply energy. The painful spot is not always the pain generator. The lectures around mine already discuss shockwave outcomes and clinical applications, so I will ask a different question. Not only does ESWT work for MPS, but where should it go? My answer is to the anatomical gate behind the trigger point. This idea comes from my chapter on shockwaves for nerve entrapment points and Stecco's center of coordination points. Pain is neural, but nerves live inside soft tissue. So we narrow the cause toward the nerve while expanding the target to fascia, vessels, muscle, ligament, joint, and movement. Why do many patients improve temporarily and then return? The concept is too muscle-centered. The origin of overstrain is missed. The technique treats the spot, not the interface. And systemic drivers such as sleep loss, obesity, and metabolic inflammation are often ignored. The classical trigger point model is useful but incomplete. It explains overload, end plate noise, taut band, energy crisis, and referred pain. My expanded model adds one missing step. Fascial densification reduces gliding. Then ordinary movement becomes compression, friction, traction, and nerve stress. This slide shows the superior cluneal nerve as a true anatomical gate. The nerve crosses the thoracolumbar fascia over the posterior iliac crest. At this interface, the nerve can pierce fascia and rub on the crest. The treatment target is the gate, not only the distal painful spot. Now we move to the first clinical case, medial knee pain. Many patients are labeled as osteoarthritis, pes anserinus tendinopathy, or medial collateral ligament pain. Those labels matter, but the medial knee is also a neurofascial region, not only a joint or tendon region. The logic is point, gate, and actual target. The tender medial point may be the alarm. The hidden gate may involve the saphenous nerve and infrapatellar branch at the fascial interface. So the RPWT target is the tender fascial gate that restores gliding and improves function. On the actual target map, I focus first on the saphenous and infrapatellar branch gate near the vasto-adductor membrane and adductor canal interface. A secondary fascial target is the vastus medialis region. The goal is not to chase every tender tendon, but to restore gliding at the gate. The second case is ulnar side wrist pain. The patient had pain while carrying objects and improved immediately after RPWT. The important point is not only that shockwave worked, the important point is where the response occurred and what anatomical structure explains it. Here I mark DCBUN, the dorsal cutaneous branch of the ulnar nerve. When ulnar wrist pain is described as TFCC or ECU pain, we should still ask whether a sensory nerve gate at the FCU ulnar styloid interface is contributing. For ulnar side wrist pain, three fascial targets can be useful. One target is the distal FCU tendon region, another is the medial intermuscular septum, a third is the hypothenar fascia. But the organizing concept is one sensory gate, the DCBUN and its fascial environment. The third case is referred pain from the low back. Not every radiating pain is a disc problem. If imaging is not significant or nerve root block does not solve the pain, I look for peripheral gates around the rib cage, iliac crest, and posterior pelvis. One gate is the subcostal nerve. In rotation-related pain beneath the 12th rib, the target is near the quadratus lumborum and posterior inferior serratus insertion. This region can mimic low back pain, rib pain, or lateral trunk pain. For the subcostal nerve, I do not treat only the pain label. I measure the rib and QL plane, find the interface between rib edge fascia and QL, and treat the tender gate. A simple rotation recheck can immediately confirm whether the gait was clinically meaningful. Another gate is the superior cluneal nerve. It exits through the thoracolumbar fascia over the posterior iliac crest. When this gait is sensitive, the pain may look like pseudo-sciatica or lateral thigh referral, even without true lumbar radiculopathy. In practices, I scan the iliac crest and find the bony edge with the fascial cleft. Then I confirm the gait by local tenderness and sensory referral. Treatment is directed to the SCN gliding interface, just below the summit of the iliac crest. The middle cluneal nerve is another important posterior pelvic gait. Around the caudal PSIS, long posterior sacroiliac ligament, and gluteal fascial insertion, the nerve can lose gliding and reproduce buttock or posterior pelvic pain. For the MCN gait, I palpate near the caudal PSIS and sacral border, then localize the long posterior sacroiliac ligament plane. The treatment target is not simply the SI joint line, it is the nerve fascial gliding restriction at the posterior pelvic gate. Across all three cases, the mechanism is the same. Fascial densification reduces gliding. Reduced gliding creates compression, friction, and traction. The nerve becomes mechanosensitive. Persistent input then drives protective motor output and neuroplastic adaptation. Finally, we must remove the drivers. Local drivers include painful gaits and fascial densification. Regional drivers include posture, spine, and kinetic chain. Systemic drivers include sleep loss, obesity, insulin resistance, and inflammation. If we ignore them, the same point returns. Sleep is not just recovery advice, it is pain modulation therapy. Sleep deprivation amplifies pain sensitivity and weakens inhibitory control. In recurrent MPS, I ask about sleep at every visit because restoring sleep quality can reset pain gain control. Obesity is not only a loading problem, it is also an inflammatory pain amplifier. Adipose tissue dysfunction and cytokine signaling can prime nociceptive pathways. In recurrent MPS, metabolic health should be managed alongside ESWT, not after it. Chronification is a cascade. First, the peripheral nociceptor becomes sensitive, then the spinal cord amplifies the signal. Later, cortical maps and behavior change. Nerve compression, sleep loss, and obesity can accelerate this transition, so they should be treated early. ESWT can act locally on the trigger point, but the strategy should be broader. Identify the gait, apply energy to the gait and the tender zone, then remove drivers such as sleep loss, metabolic inflammation, and repetitive load. This is part of treatment, not extra advice. So neuromyofascial release is not just pressing harder, it is a clinical strategy. Treat the point, target the anatomical gait, restore gliding, remove local, regional, and systemic drivers, then recalibrate movement and pain modulation. Thank you for your attention. I hope this lecture helps you look beyond the painful point and search for the anatomical gait. I welcome your questions and clinical opinions. Please scan the QR code for contact and follow-up discussion.